Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am so excited that today we're going to be talking about a topic we've never been able to share before. This is cataracts, diagnosis, surgery, and intraocular lens selection. I have Dr. Brock Bakewell here with me. He is with Eye Associates of Tucson. How are you today, Dr. Bakewell?
Doing great.
Good. So I want to just share a little bit about you, if I could. He is an ophthalmologist with Eye Associates of Tucson. You specialize in small incision premium cataract surgery and refractory surgery, and you're certified by the American Board of Ophthalmology, and you are also a fellow of the American College of Surgeons. So I know you've got quite a presentation today. I know there's some videos and a lot of information. I know that so many of our seniors have issues with cataracts. So I'm going to go ahead and put your PowerPoint up. You do have an online audience that's watching with you today, along with an in-person audience. So if you're watching from home, please feel free to put any questions into the chat and we'll address those afterwards. I'll turn it over to you, Dr. Bakewell.
Great. Well, it's great to be with you this afternoon. Just a little bit about me. I grew up in Pennsylvania, Western Pennsylvania. So yes, I'm a Steelers fan. And I went to medical school at Jefferson Medical College in Philadelphia, and then did an internship in Pittsburgh, and went to the University of Virginia in Charlottesville, where I did my residency in ophthalmology. And then I did a corneal and glaucoma fellowship at the University of Utah, which got me out west. And I've been here in practice actually over 35 years. So these are my financial disclosures. I get some study income, but this really doesn't have a bearing on this talk. I recently jumped ship by joining Eye Associates. I was in practice with William Fishkind in town for over 35 years. And for one reason or another, I changed direction and went with a different practice, and you might wonder why. And the reason is, to put it in ophthalmologic parlance, my younger partners and I did not see eye to eye anymore. So I went a new direction, and our senior partner at Eye Associates is Michael Diesenhaus, and the rest of our MDs, Lauren Kaplan does glaucoma, Melanie McCarty does plastics and cataract surgery, Archana Reddy does general ophthalmology and cataract surgery. And then we have two great optometrists, Patrick Kollrick and Shannon Friedmeier. We have two locations. I'm only at the La Cholla location, but there is a Night Drive location on the east side. We're going to start with a little bit of ocular anatomy here. The eye is a very complicated thing, even though it's a small organ. The cornea, the front part of the eye here, well, I didn't mean to... Okay, the front part of the eye, it's only 0.5 millimeter thick in the center, but it does most of the refracting of the light that comes into the eye. The lens, which is behind, outlined here, that's basically what turns into a cataract as we get older. It gets thicker and more opaque with time. But light comes into the eye, it's refracted by the cornea and the lens, and then it hits the retina. And so the light energy is turned into electrical energy, and it actually goes back in the brain through the optic tract, or through the optic nerve and the optic tract. And then we actually see with the very back of our brains, the occipital cortex, which you can see here. This is the lens, the crystalline lens. It's an amazing structure. When we're younger, it has the ability to get very thick, which allows us to see up close. And it gets thin, and we can see at distance. As we get older, the lens gets stiffer. So once you get to be age 40 or 45, if you've had perfect distance vision, you start to have near vision problems because you lose accommodation. So the lens in the eye provides about 1/3 of the focusing power of the eye. The rest, 2/3 of the focusing power is done by the cornea, the very front structure of the eye. And this lens constantly grows throughout life. 25 microns a year. That's 25 thousandths of a millimeter. So the lens is constantly growing. Everybody gets some degree of cataracts with age. It's just normal. And so light comes into the eye. It's focused by the cornea and fine focused by the lens, and it's focused onto the retina. Now, not everybody has a normal eye like this. Here's an example of a normal eye, and they're looking at this distant target, which happens to be the number 5, and it's focused by the cornea and the lens, and it's focused right onto the retina here, right here. And so this person can see fine at distance without glasses, and if they're young enough, they can see up close without glasses. If you're farsighted, then your eyeball is really too short. There's not enough refracting power in the eye. And so you end up wearing magnifying glasses, first to read, but then eventually for distance. So this is something that can be corrected when we do cataract surgery. We can put a stronger lens in the eye than your God-given lens. Here's the opposite situation. It's a nearsighted eye. It's longer than average. It has too much refracting power in the eye. So the cornea and the lens together provide too much refracting power, and the image focuses in front of the retina. So people that are nearsighted can see some place in front of their face. It may be very close. If they're very nearsighted, it may be a little farther away, but their distance vision is fuzzy without wearing glasses or contact lenses. Astigmatism is something that you probably hear about. And what is astigmatism? It means the front of the eye, the cornea and the lens, they are not round like a basketball. They create, they're more of an elliptical surface like a football. And so if you have two different shapes, then you create two focal points, which are manifested here in front of the retina. You have these two focal points, and they're not in focus on the retina, so things are blurry. You get more of a ghosting or double image when you have astigmatism. That's something else that we can correct at the time of cataract surgery. So what is a cataract? Basically, it's just a clouding of the normal lens. You can see in this diagram, it comes into the eye and it's focused nicely on the retina by the cornea and the lens. If you have a cataract, the light is scattered so that you lose contrast, you get ghosting around lights, and your color vision decreases somewhat because of the loss of light. And so a cataract is just a cloudy lens that occurs usually with age. So what are the symptoms? Well, I've mentioned you get blurriness of your vision, you get a reduction in contrast, you may need more light to read. You may see halos around lights at night when you're driving. You may get glare or starbursting from lights, and you may get a double or ghosting image from that cataract or whichever eye has a cataract. So what causes cataracts? Well, I've said the most common cause is age-related. Everybody gets some degree of cataracts with age. There are other causes, though: traumatic, physical trauma, surgical trauma, also inflammatory conditions such as iritis, which is just an inflammatory, not an infection, but an inflammatory condition inside the eye. It can also be congenital. The lens forms by the 6th week of life after conception. So if the mother has an infection like rubella within the 1st trimester, it can cause a cataract. There are medications that cause cataracts. I mean, steroids, prolonged use of steroids like prednisone, people need that for rheumatoid arthritis and other inflammatory conditions. Even topical and inhaled steroids, if you took them enough, could potentially give you a cataract. Hereditary cataracts can occur. Usually these occur in the 2nd, 3rd, or 4th decade of life. Diabetes is certainly a risk factor and causes cataracts at a younger age than the normal population. Highly nearsighted people have a higher risk of cataract developing. Smoking is a risk factor for earlier cataract development. Ultraviolet exposure, that's why we tell you to wear UV protecting sunglasses when you're outside to cut down your UV exposure. The possibility of exogenous estrogen and alcohol, they may be factors. It depends which study you look at. And the increased body mass index may also be a risk factor. So you can see it's not just one thing, but the most common cause is age-related. Here on the left, you see a golden brown lens. And this is a pretty mature cataract. This person might only have 20/60, 20/70 vision. In this country, people usually get cataract surgery, maybe even before this level. In a third world country, they get worse than this before they get health care. On the right, you see these cortical spokes. This is a diabetic cataract. They get these little spokes which cause glare when you're looking at light. Here's a nice visual. On the left is a normal eye. On the right is an eye that has a cataract, or the vision of the eye with the cataract. You can see there's blurriness of vision. There's reduced contrast. The colors are drab, and even there's a little bit of ghosting there. So these symptoms sneak up on you, though. It's not like suddenly one day you wake up and say, wow, I see that. It happens so gradually, so surreptitiously that you almost don't recognize it. And then, but at some point you reach a threshold where you realize your vision's not as good as you want it to be. Here's a posterior subcapsular cataract. This is due to prednisone. It can be due to other causes, but this causes a ton of glare from sunlight or headlights. On the right, you see a mature white cataract. I mean, that person sees only light or maybe a little bit of hand motion, and that's a third world cataract. But there are people in the United States that still have cataracts that get that bad. They don't have access to health care insurance, and they, it's not uncommon that we see some of these, not that many, but we do see some in the United States. Here's that patient that had the posterior subcapsular cataract. You can see this patient can barely see the child sliding down the sliding board because the sunlight causes so much glare from this type of cataract. So the question is, who should have cataract surgery? When should you have cataract surgery? Actually, it's a very individual decision. I mean, I don't dictate to people that they need to have cataract surgery unless they can't pass their driver's test and they want to keep driving. Then I'll say, well, you need to have cataract surgery. Otherwise, it's a quality of life decision. I mean, you can't see your golf ball. You can't see your fine needlework, even under high magnification. You can't see to drive at night very well and you like to go to the opera or you like to go out at night. So you pretty much know when your lifestyle is affected, then you really want to do something about it. An old term that used to be used was ripe cataract. I'm going to have cataract surgery when my cataract's ripe. Well, that's not a term we use anymore, but you got to realize the way we used to take cataracts out, we made a big incision in the eye, 14 millimeters, and we popped the cataract out like a tiddlywink. So it had to be hard enough that it didn't break up when it came out of the eye. Now we can take cataracts out with any degree of hardness or softness because we use an ultrasound, which I will show you in a little bit here. So that's an outdated term. What you need to know is when your vision has deteriorated to the point where you're not happy with how you're seeing, then it's time to consider cataract surgery. Medicare says you should be 20/30 or worse under some condition. Now, you could be 20/20 in a dark room, but as soon as we shine light in your eye to simulate nighttime driving, your vision drops to 20/50 or 20/80, and that is an indication that you need cataract surgery. I had a patient come in once. He was an equestrian judge. He had one eye. His other eye, I don't know how it was damaged. I forget, but he couldn't see across the rink to do judging of these horse shows. So he'd been to several ophthalmologists in town, and he hadn't. No one would operate on his cataract because it didn't look that bad. Okay, it didn't look that yellow brown. It didn't look bad enough. And I said, well, I think your vision will improve, but I'm not positive. I don't know that it's going to do what you want it to do, but he couldn't do what he wanted to do. He couldn't judge anymore. So he did his cataract surgery and he got a great result. We had the biggest bouquet of roses on our front desk the next day. So people can tell when they can't see what they need to do, and that's the biggest indication to have surgery. So we use something called phacoemulsification. That's ultrasonic breaking down of the lens. This is a technology that was actually invented in 1967 by Charles Kalman. He was quite an inventor in New York City. He was at his dentist's office and he thought, ultrasound. We should be able to take cataracts out by just breaking them up. And so his early prototypes were met with a lot of resistance from the established medical community, but he kept going with it. And by the way, this is all done with microscopes now. We used to use magnifying loops to take cataract surgery or to take cataracts out. Now we use microscopes that we can create a lot of magnification. And so I mentioned phacoemulsification. This is my previous partner, William Fishkind, who's retired now, but he's showing with this jackhammer. This is what the ultrasonic lens does. And the ultrasonic phaco handpiece, it vibrates 40,000 times a second and breaks the cataract up into tiny pieces. And then we suck it out through the hollow needle. And this phaco handpiece also has an irrigation sleeve. So we're irrigating fluid into the eye to keep the eye inflated while we're taking the cataract out. And then the second part of the procedure, after you have the cataract out, we put a lens implant in. And I'm going to spend some time talking about lens implants. But this is put in the same little cellophane bag from which we remove the cataract. So we have the cataract, we peel an opening in the anterior surface of the cataract, that's called the capsule. We take the cataract out with ultrasound, and then we put a new lens implant in the same little cellophane bag from which we remove the cataract. So it's very slick. And these lens implants, you can see here, they're very small. The overall diameter is less than the size of a dime. And the optical portion of it is about 6 millimeters. The overall diameter is about 13 millimeters, 12.5 to 13 millimeters. And so the early lens implants were not foldable. They were one piece. So we had to open the incisions to at least 6 millimeters to put these in. And then in the 90s came foldable lens implants, which I'm going to show you here. This is my surgery. I'm putting a foldable lens in, injected it through a syringe, and then these materials, acrylic or silicone, they open up and they create a full 6 millimeter optic inside the eye. So this goes along with the smaller incision that the phacoemulsification afforded. We also have lens implants that go through smaller incisions. So Harold Ridley, a physician in the United Kingdom, was the first one to come up with a lens implant, 1949. He made a great observation. The pilots in World War II that were shot, their windshields were shot, there are pieces of the windshield that got embedded in the eye, and the material was very inert. It did not cause a lot of inflammation. So that's why he chose polymethyl methacrylate or plexiglass windshield as the first material for a lens implant. And then we got flexible silicone, and we got acrylic materials, which are the ones that we use today, silicone and acrylic materials, so that they can be foldable and go through a small incision. In terms of cataract incision size, 50 years ago, I told you we had to make a 14 millimeter incision. We took the cataract out in one big piece. 30 years ago, we got down to 2.5 millimeters. And now you can even take a cataract out through two little 1.1 millimeter incisions. The problem is we don't have a lens that will go through that small of an incision. You still need 2 to 2.5 millimeters to put an existing lens implant in the eye. So I want to talk a little bit about what happens once your cataract's diagnosed, and then we do measurements of your eye. That's called ocular biometry. And we measure the different aspects of the eye. You can see here, we measure the corneal, the curvature of it. We measure the thickness of the lens. We measure the length, the axial length. That's from the cornea to the retina. And we measure what's called the white to white, which is basically about the size of the iris. We measure the pupillary size. We measure all these things, which are all very important. And but it's important that these measurements be very precise, because if they're not precise, then garbage in, garbage out. We're not going to get a good measurement for your lens implant, and we may pick a lens that doesn't work that well for you. So there are things that you have to fix before you do cataract surgery. Many of you, I'm sure some of you have dry eye. This is what you see with dry eye when you put yellow dye in the eye. It stipples, like I took a magic marker and made a bunch of stipples. You have to treat dry eye syndrome before you do cataract surgery, or your measurements will not be that great. So you use artificial tears. We use anti-inflammatories like Restasis. We'll put plugs in your tear drainage ducts to boost your tear film. If you have a lot of dandruff-like flakes on your lids, we have you use lid scrubs, have you take omega-3 fatty acids, which are fish oil, and sometimes oral tetracycline. So you got to tune up the surface before you do biometry. There are other things like ABMD, anterior basement membrane dystrophy. Another name for that is map dot fingerprint dystrophy. These little areas in the front of the cornea, and they're in the corneal epithelium, they distort the surface of the cornea. They cause irregular astigmatism. You have to scrape this, this irregular skin off the surface of the cornea, let the eye heal for 3 months, and then come back and do your measurements for cataract surgery. There are other things. You can see these white nodules here on the cornea. This is Saltzman's nodular degeneration. This causes irregular astigmatism. You have to take these off, let the eye heal for 3 months, and then come back and do biometry for cataract surgery. There's other things like this pterygium here. See this fleshy growth on the cornea? This is due to ultraviolet exposure. It's a fleshy membrane that grows out onto the eye, and this has to be removed. And I do these. I take a graft from up under the lid and I splice it over this area, because if you just cut it off and you don't put a graft on it, it's going to grow back 25 to 50% of the time. If you put a graft on it, it only grows back, well, less than 1% of the time. But this is causing distortion of the cornea. You've got to take care of these things before you do ocular biometry. You know, and my clicker is not working currently, so we'll see if we can do it this way. Well, let's see here. It's not.
There, try now.
Okay, so I want to show you what some of these conditions do to the eye. This is a patient that has nodules on their cornea. Up here where it's very flat, it's flat like the ocean. It's blue. These are very elevated like a mountaintop. Okay, this is irregular. You can look at it another way here. You can look at how these circles are distorted on the cornea. Okay, this is all due to these nodules. And there's a lot of astigmatism. 4 diopters. What does 4 diopters mean? It's 16 clicks on our big pair of glasses. That's a lot of astigmatism. And then there's a lot of higher order aberration in the eye, which is RMS, root mean squared. And there's other high order aberrations. So these nodules are affecting the vision. If you just put a lens in the eye to correct 4 diopters of astigmatism, you're going to have an unhappy patient. What I did was scrape these nodules off the cornea and wait 3 months. These are the measurements now. Look how much more smooth these are. You don't see big differences between, you know, blue and the top. There's some difference there, but look how round the circles are now. And our astigmatism went from 4 diopters to 0.1 diopter. That's less than 1 click. This person does not need to have their astigmatism corrected at the time of cataract surgery, because we got rid of their astigmatism by scraping the cornea. Also, the total aberration in the eye is much less than the previous situation. The same with the coma, which is another high order aberration. So you got to take care of the surface. Once we've taken care of the surface and we've gotten good measurements, we have to put them into a common day or a 4th generation lens formula. So we put the axial length in, we put the keratometry, that's the shape of the cornea. We put the anterior chamber depth, that's the space between the cornea and the lens. And we put our desired endpoint. How does a person want to come out after cataract surgery? Do they want to see perfectly at distance? And are they willing to wear reading glasses? Or they've always been nearsighted and they may want to see up close, but then they're going to wear glasses for distance. Or maybe they want a multifocal lens, which tries to give you both, but it is a compromise a little bit. And then we put in the thickness of the lens, we put in the white to white. So we put in all these things we've measured, and it'll give us the power of the lens that we put in, and then we put that in the eye. Now, there are other twists that occur when taking measurements. Some people have had LASIK. How many people have heard of LASIK or PRK? Anyway, those are refractive surgical procedures, and radial keratotomy was a refractive surgical procedure prior to PRK and LASIK. So those corneas are even more, they're different. The shape of them is different. So we have to put their data into the American Society of Cataract and Refractive Surgery calculator in order to get a best guesstimate of the lens. But all these things give us a best guesstimate. There's no surgeon anywhere in the world who can put a lens in you and say, I guarantee that's going to be 20/20. I mean, certainly we shoot for perfection, but it's not always, it doesn't always come out perfect. It can be off a little bit, a half diopter, and most people can live with a half diopter or less. But let's say it's not right. Well, then you want to make it better. Sometimes we have to do a lens exchange, and not all surgeons do lens exchanges, I can tell you. I'm one that does a lot of lens exchanges because people who aren't happy elsewhere come to me, and I will exchange their lens and make them happy. Or I'll do PRK, which is a refractive surgical procedure, and there are only about 4 of us in town that do PRK and LASIK. So I'm just pointing out, astigmatism can very much vary. This is regular astigmatism. This is irregular. The top of the cornea is different. This is normal, regular astigmatism. So not everybody who has astigmatism can be perfectly corrected with a lens implant that corrects astigmatism. This is the retina. That's another thing that we look at before we do cataract surgery, because if you have a retina that's abnormal, if you have macular degeneration and have fluid under your retina, or you have cystoid macular edema, you're not going to like your result after cataract surgery because the film in your camera isn't what it should be. So you have to sometimes get the retina in better shape before you do cataract surgery. So our goal is to, after we've done measurements and we've talked to you about what you want, we want to match the visual expectations plus the visual limitations of your optical system with the best lens implant for you, okay? It used to be years ago when we were just doing cataract surgery in the 70s and 80s. I wasn't doing it in the 70s, but when it used to be you put the same lens in everybody because we couldn't differentiate between one cornea and another. The science hadn't advanced that far, but now it's very advanced. So there's certain lenses that we wouldn't put in certain people that have certain issues with their cornea. So there are a bunch of, these are basic considerations for lens implants. I mean, you can have a monofocal lens. That means a single vision lens. You can have that put in your eye. You can have it put in both eyes for distance. But if you do that with a single vision lens, you're going to be wearing reading glasses to read most likely, unless you have a very small pupil, which creates a greater depth of field. Now you can do the opposite. You can do, I didn't finish with multifocal. You can put single vision lens implants in for near, so you can maintain your nearsightedness. If you've always been nearsighted, you can see great up close, but to see at distance, you're still going to be wearing distance glasses. If you want to hedge your bet, you want to make one eye, you can do monovision. You can make one eye for distance and one eye for near, but not everybody loves that, okay? If a lot of people have done that with contact lenses, and if they like it with contact lenses, they'll certainly like it with cataract surgery. So, and sometimes we'll try a contact beforehand if you think you might like monovision, but if you have a dense cataract, then you don't get a real feel for what monovision's like. And then the third option is a multifocal lens. And multifocal lenses have gotten better. They're not perfect though, but some people love their multifocal lens implants. Other people don't like them as much. So the trick is to try and figure out who will like them and who won't. And part of it is you've got to make sure their eyeballs are good candidates for multifocal lens implants. And there are a bunch of different lens implants. These are current monofocals. These are Alcon lenses. This is Johnson & Johnson. This is Bausch & Lomb. And then there are a lot of what's called extended depth of focus. Extended depth of focus lenses, they give you, they're like a monofocal. They give you good distance, but they give you some intermediate, okay? But they don't give you the same thing as a multifocal lens, which some of you may have heard this if you're looking at cataract surgery. PanOptix lens, Synergy, Odyssey. Odyssey is a new, relatively new lens. It's been out a couple of years by Johnson & Johnson. The Envy lens by Bausch & Lomb. And then there's a PanOptix Plus that just came out in the past couple of weeks, or the past month or two. So these are multifocal lenses. They give you pretty good distance vision, not as good as a single vision lens, because you're taking a lens, you're dividing the light between distance and near. So you're not getting as much light for distance as a person that has single vision lens implants, if that makes sense. You're getting only some of the lens focused at near. You're not getting the whole lens focused at near. So your near vision isn't as good as somebody who puts single vision lenses in their eyes for near vision. So, and then the last category, these lenses are not FDA approved. These are truly accommodative lenses. These are the holy grail of lenses, but we don't know if they're ever going to be approved. But these lenses actually move in the eye like the original crystalline lens. So this is going to give you the best of both worlds if and when it comes. I think it will come, but I don't know that it's going to be anytime soon. But think of this. So the lens in its flattened shape is going to be focused at distance. And then if you want to see up close, the lens will get thicker. It'll function very much like the crystalline lens does in your eye prior to the age of 40. But whether or not these are going to be forthcoming, we'll have to see. I just want to show you, this is a topography that we do. I showed you previous topography. This shows perfectly normal astigmatism. It's vertically oriented. It's like a football. The strings are vertical, and it's 3.5, 3.4 diopters of astigmatism. Well, we have lens implants that'll perfectly correct that. And I can tell you, in a person that we put lens implants and correct this much astigmatism, they say their vision's better than it's ever been in their life without glasses. So we're doing stuff in ophthalmology that makes people better than they've ever been in their life. I mean, it's truly a gift to be an ophthalmologist. I love being an ophthalmologist. My dad was a general surgeon. Okay, no one ever probably thanked him for taking their gallbladder out. But at any rate, I love ophthalmology because what we can do. We make people happy and we make them see better than maybe they've always seen. So all the companies have various powers of astigmatism lens implants, from 1 diopter, which is 4 clicks on our machine, down to 4 diopters. And in Europe, they even have 6 diopters, but our FDA hasn't approved that. So when we're putting a toric lens in the eye, these little marks on the lens, that is the axis of the astigmatism. So we align that with the astigmatism, and that's what mitigates the astigmatism. And all the companies, this is Johnson & Johnson, they have, they all have a similar selection of lenses. This is Bausch & Lomb. So these are all really good lenses to correct refractive error, correct astigmatism. And then these are some older multifocal lenses from about 10 years ago. Notice there's a lot of contrast loss. So you're not getting 100% of the distance light into your eye. You're only getting about 70% of it. That's why your distance vision isn't as good with a multifocal. Now, the newer multifocals are better than this. You're only losing maybe 15 to 18% contrast compared to these older versions. So what are the various pluses and minuses here? Well, the multifocal lens, it sounds like the best. I mean, you get a pretty full range of vision for distance, for near and intermediate, but you get halos around lights at night, and for some people that's bothersome. Other people it's not that bothersome. You get some contrast loss because not all the light is getting into the eye for distance, and not all the reading light is getting into the eye either. That would occur with a similar monofocal lens. And so you have to decide what you want. And If you decide you think you want a multifocal, well, the other thing, I haven't talked about cost either. Medicare pays for a standard lens. They don't even pay for astigmatism, okay? They don't feel like that's necessary. They look at it as being kind of cosmetic. You can wear glasses and see, but if you want to see without glasses, then you have to, do an astigmatism lens, and that costs more money. Multifocal lenses cost even more money than a toric lens, which is for astigmatism. So this is just a representation of some of the spider webbing lights that you might see from a multifocal. This is from a multifocal like the Technis or the Panoptics, or not it's the early version of the Alcon lens and the J&J lens, the Technis lens. The newer ones, the Odyssey, the Envy, the Panoptics Plus, don't cause this much, but you're going to have some of this, and your brain will adapt to some of that as time goes on. So it won't be this screamingly obvious to you, but you'll still have it. And some people are bothered by that. Other people aren't bothered by it. I wanted to bring up one other lens called the IC8 lens. This is the AccuFocus lens. This is also called the pinhole lens. If you know anything about cameras, if you take a picture with a very small aperture, everything in the foreground, everything in the distance is in focus. Well, that's what this lens tries to do. You leave the patient slightly nearsighted. They see pretty darn well at distance, pretty well up close, but there's a contrast loss too, similar to multifocals. So usually we only put this in one eye. This study was done in Tucson. I did the only lenses in Tucson from this study. I put in 13 of them. This was FDA approved back in 2022. We sometimes use this in people that have irregular astigmatism too, because this pinhole mitigates a lot of astigmatism. You're only letting the central light rays into the eye, not the peripheral light rays. So this is, distance vision for a small, or this is a very large pupil. Everything in up close is okay, but the distance is fuzzy. When you have a small pinhole lens, everything up close and everything at distance is pretty clear. So that's another lens that could be used. I like these extended depth of focus lenses because the Eye lens from J&J. There's also another one from B&L that I didn't put up here, but these give you good distance, decent intermediate, and actually, and you're out in bright sunlight, your pupil gets smaller. You can probably read newsprint, but you're not going to read it at night with the lights dim. You're going to put on reading glasses, but these lenses are pretty darn good for your all-around vision, but you're going to wear reading glasses still, unless we make one a little bit on the nearsighted side, and then you may get by without wearing them. I want to talk about one other lens, the light adjustable lens. This is a really cool lens. It was under 15 years under development, but this is a lens that we can change the shape of after it's in your eye. Okay, so you come out a little off, half a diopter. Well, we can, let's say you're off significantly 2 diopters. That's 8 clicks on our little machine. We can actually take that from 8 clicks to 0 click just by treating the lens with ultraviolet light. And same thing, you could be -2 diopters nearsighted, and if we're off that much, we can treat that with ultraviolet light, and we can treat a lot of astigmatism too. So this is a really cool lens. We have the ability to adjust people after the fact. We don't do the adjustments for at least 3 weeks after standard cataract surgery. If you've had previous radiokeratotomy, I don't do the adjustment for 3 months. So during that time, you have to wear these ultraviolet protecting glasses, because if you're outside in the sunlight, the ultraviolet could affect the lens shape. So this lens, it comes from the company. It's 75% polymerized, and then we can change the shape of it because we can move the molecules around in the lens. So it's kind of cool. But you have to be able to dilate to 7 millimeters. A lot of people are on medication, like especially men, they're on Flomax to prevent a lot of urination at night. And that causes the pupil to be small, and you just can't go off the medication and have it reverse. So it's not everybody's a candidate for light adjustable. I just wanted to tell you about it. But this is the scattering of the results in patients that have standard lenses. Notice that the end result is much tighter in the people that have light adjustable because we can adjust it after it's in your eye. And you want to wait 3 weeks at least. And then, yeah, you can do up to 3 adjustments with this lens. And then when you have it where you want it, you lock it in with 2 additional treatments. So it's a lot of work. It's a lot of office visits. Some people, they don't want to spend that much time. And so we're seeing each other a lot if you do a light adjustable lens. And this is an expensive lens as well. I want to talk a little bit more about astigmatism. This is a level that I developed in conjunction with Mastel. This is how I used to do astigmatism treatment. I had the patient sit up on the gurney at the operative center, and we would make a horizontal mark on their eye, because if we don't mark their eye, when they lie down, the eye rotates, and you've got to put the toric lenses at the correct axis so they're not going to work. For each degree that you're off, you lose 3.3% effect of the toric lens. Here I am having the patient sit up, and this is a carpenter's level. I've put some indelible ink on the marks, on the little marker, and you can see I've made a horizontal mark on the eye here. As soon as the level comes away, you can see the horizontal mark on the eye. And so that's how we used to do it. We've got a little bit more sophisticated with electronic markers. And also there's a laser that I want to talk to you about. This is a cataract surgery, one of mine that I did. And I'll explain this to you as it goes. It's an astigmatism lens. So I've marked the patient in the preoperative area, and we're marking them in the operating room. We're at 100 degrees is where the patient's astigmatism is. And then these are diamond blades that we're making a little mark into the eye. We're putting some extra dilating medication in. We use a little viscoelastic jelly to open the eye and to protect the inside layers. This is a 2.5 millimeter incision. I'm making a little stab incision in the capsule. And then this is a 5 millimeter mark. And I'm going to make a 5 millimeter opening in the lens covering. And this is all manual. And so you're just taking your time and making a nice round circle, about 5 millimeters, which is the ideal for our 6 millimeter lens implant. And then we put fluid under the capsule to hydrodissect the cataract away from its covering. And we also inject a little bit of fluid inside the lens itself. You'll see a nice golden ring that formed. Now we're putting our phacoemulsification probe in the eye. This is our ultrasonic needle, and I'm chopping it some with my left hand too. I'm chopping it into pieces, and we're going to take these pieces out piecemeal. And it just, it takes some time to do this. You don't want to tear any of the membranes. You don't want to create a problem. So you take your time and just take the pieces out that you've created. And they're all being sucked out through the tip of that needle. And then we've taken all the hard stuff out, and now there's some billowy, what we call cortex left. So we're going to take the cortex out with what's called an irrigation aspiration device. This is stringy stuff that comes out. We're cleaning this little bag from which the cataract was removed. We're getting all the little lens material out of there. And then we're going to put a lens implant in, and we're going to align it with our marks that were made on the cornea. So this is a toric lens that I'm going to be putting in, and I'm also cleaning the capsule a little bit there. This is the lens. It's been rolled up into a syringe, and it's being injected into the eye, and then it will unfold gently, and then we will align it with our marks on the cornea. And I also like to scrape the underside of the capsule to get as many cells off as I can, because if you have to go back in the eye and exchange a lens, it's a lot easier if there's not much fibrosis. And then we're going to align our lens. You'll see here, we're going to align the little dots, these 3 dots on each side. We're going to align them, make them parallel to our indelible ink marks. And so we're all aligned there. And these lenses won't rotate. Earlier models did, but it'll stay right where we place it. And like I said, it's important to place it at the right axis. If it's off 10 degrees, you've lost 30% of the effect of the toric lens. Now I want to share, I told you, I mentioned the laser. The laser is really cool because we do these topography measurements, and it actually registers on the iris, so that then we take it back to the laser, and the laser will make the marks on the capsule exactly where the astigmatism is. So I want you to watch this for a second. And I was trying to stop it here. Hang on a second. Let me just, I still can't stop it. It should be able to stop. There it is. See these little marks? Mm-hmm. That's in the capsule. It was done by the laser. That's exactly where I want to center my toric lens. So it's getting more exacting. What I'm saying, this is robotics. Okay, this costs more money too. Medicare doesn't pay for this kind of stuff. They say, well, you can do it manually, and you can do it manually. And I'm a very meticulous surgeon. But if you took 10 surgeons and they all did laser, their eyes are going to look about the same. If you did 10 surgeons and they all did manual surgery, it's all going to look somewhat different. I'm not saying it's bad. I'm just saying it's different. This is more precise. So to be able to do that, and it's not on the cornea, it's at the level of where I'm placing it. So it's very cool. And not only that, watch the rest of this. The light cuts the lens up into pieces here. Sorry, let me just hit that again. The light cuts the lens up into pieces, which you will see here next. You haven't seen it yet. Here it is. It cut it into 4 pieces there. And so it's making it easier to take out the cataracts, okay? Easier for the surgeon. And then this is the other laser video that I had. And this will make make the mark, and it'll cut the lens into 6 pieces. So you can program the laser and it makes it easier for the surgeon. So it's just cool stuff. It's very cool. I mean, ophthalmology was the first specialty in medicine to utilize lasers. So we're very much ahead of the game in medicine. So I wanted to also talk to you. Sometimes at the time of cataract surgery, we do something for glaucoma too. That's called a MIGS device, micro-invasive glaucoma. You can see these little stents that were put in here. These are called eye stents, and they're very tiny. You can see this is Lincoln's head on the penny. These are very tiny. They're 50 microns, but they help to lower your pressure and help to get you off, potentially get you off some drops. And I wanted to just remind you too, let's say we missed the end point of the lens implant. We put a standard lens in. We didn't do a light adjustable lens. We put a standard lens, and it didn't come out as well as you wanted. It's off a little bit. Okay, well, if it were off a lot, I would probably take the lens out and exchange it. If it's off a tiny bit, I'd probably do a little PRK, which is to laser the cornea just to change the shape of it. This was FDA approved in 1995, so it's been around for 30 years. PRK works great. So I'm just letting you know, the ball game's not over after the lens is in your eye. If you're not happy, we can either do a lens exchange, or some of us will. Some ophthalmologists won't go back in. And then, like I said, PRK, I'm one of 4 people or so in town that does PRK that can touch your eye up. So in summary, I know I've given you a ton of stuff to think about here, but so we want to always do a thorough patient history to determine the past ocular history, to see if you've had previous LASIK or RK. We want to see if you have any surface disease, dry eye, Saltzman's nodules. And we've got to find out what you'd like to achieve. Do you want monovision? Do you want both eyes set for distance? You want both eyes set for near? And then we want to do precise biometry. Your measurements are really important. We put them into the 4th generation formulas. We also do topography to make sure you don't have an irregular shape on your cornea that would rule you out for maybe a multifocal lens. And then we want to match the patient's, your expectations, and maybe the limitations of your optical system to choose the optimal lens implant. And if it doesn't come out perfectly, if you have a light adjustable lens in your eye, we can do the adjustments to make it more perfect, or we can do PRK to fine tune, or we can do a lens exchange. If you're unhappy with a multifocal lens, we can take it out, we can put a standard lens in. So it's not over after you've had one thing done. We want happy patients, always want happy patients. All of us at Eye Associates of Tucson are here to help you in your ophthalmic needs. So anyway, I'll take some questions, and I guess we're going to do online questions. And
Thank you. Yes, I would love to. That was amazing, and just to see how you're able to do all of that precise, all of that precision with the cataracts. I am very amazed by this. I have a couple of questions that came in, Dr. Bakewell. One is, what if mold has diminished your eyesight? Can that be helped?
say that again?
They asked, what if mold has diminished your eyesight?
Mold?
Mold, M-O-L-D, mold.
Oh, molds. Well,
Yeah.
I don't know. That would be a rare occurrence. Mold is, a yeast or a fungus. I mean, that normally doesn't get in the eye. I mean, unless, you can have it in your system. If you had, like endocarditis or something, inflammation of your heart due to some kind of inflammatory or infectious disease, it can sometimes get in your eye, and you can get corneal ulcers that are fungal, but so if you had an ulcer in your eye, that might very much affect what lens implant could be put in, because if you had a lot of irregular scarring, you'd never be a person that would tolerate a multifocal lens or a light adjustable lens. And if you have scars of your cornea, you can't do the laser cataract either. You have to do manual cataract surgery. So I don't know if that answers your question, but I mean, if you had significant scarring of your cornea and that was the limiting cause of your visual decrease, you could always do a corneal transplant to get rid of the scarring. And so that would be an option. I'm not sure where the fungus was. Usually it's in the cornea if you get a fungal ulcer.
Okay. Is there pain in the actual eye after you have one of these procedures?
Good question. There's not much discomfort. Usually it's scratchy, burny discomfort for the day of the surgery. But occasionally you can get a corneal abrasion, so it can take a day or two to heal. But usually there's not much discomfort. It depends on a person's pain threshold, though, too. If they had a very low pain threshold, then they might feel that they had a lot more discomfort. But most people say I don't have much discomfort. A little scratchy, burny discomfort is pretty much it. Some people take a Tylenol. Some people don't even need that.
Okay. So when you are getting ready to do the surgery, where do you do the surgery? You do it in a surgery center, or?
Yeah, no, it's done at most people do them at surgery centers. I operate at Wyatt Surgery Center, which is actually on the TMC campus, right off Wyatt Drive.
And how long does it take to do the procedure?
Well, it depends. The actual laser procedure takes a little bit longer because you're under the laser and then you got to move them into the operating room. But, I don't hurry. I'm about a 12-minute guy. There are guys that take cataracts out in 6 minutes, but they're not cleaning the inside of the bag as well as I do. So but usually 12 to 15 minutes.
So not long.
Medicare thinks the procedure should be done by 20 minutes. That's
okay.
That's the time.
Okay, yeah, just to give us an idea. Can you share a little bit, just share with everybody, where is your office located? Where is Eye Associates of Tucson?
Yeah, I'm at the West Side office, which is 6130 North La Cholla Boulevard. It's 3 buildings down from Northwest Hospital on the same side of the street. And it's on the 2nd story of that, but there's an elevator and everything. But it's a beautiful office. It used to be one of the Retinal Associates office, and so it's very nicely appointed. And so I really enjoy being there.
Great.
And then there's an East Side office too on Knight Drive, which is just across the street from TMC. It's not, I won't say it's a great office. It's just not our flagship office. Okay. But it's a nice office.
Okay. And I did go ahead and I've put the phone number up for Eye Associates in case somebody's looking for an appointment. 520-888-6600 is the phone number. So please feel free to give a call. Dr. Bakewell, I want to thank you so much for being here today. This was wonderful. I know you are coming back to see us in November, so we're very excited to have you come back. We're going to be talking about macular degeneration and diabetic eye disease. So we look forward to seeing you again. I'm going to wrap up with our online audience, and I will send it over to you for any of those in-person questions. Thank you.
Great. Thanks.
Thanks again for being here today. We look forward to seeing you back. Tomorrow, Thursday, October 9th, we do have emotional first aid after a diagnosis. What now? That is part of our survivorship presentations our series that's going on right now. If you're interested in this class, please give us a call. The phone number is 520-324-1960. We have a few more in our survivorship series that are coming up as well, and we'd be happy to share about those as well. We'll see you again soon. Thank you.